Um, Today, we have the pleasure of hearing from two lung transplant fellows, Dr. Joel Samuels and Dr. Ketaki Rawal. Dr. Joel Samuels trained in Vancouver and actually will be going back to Vancouver at the end of the year. And Dr. Ketaki Rawal trained at McGill University and at St. Mike's in Toronto. And we're going to have the pleasure of hearing them speak as co-presenters on the role of lung transplant in the setting of lung cancer. So I'll let Dr. Samuels and Rawal take over.
Okay. So just wanted to go over the objectives before we get into our case. So just go over a very brief overview on the staging, prognosis, and treatment of lung cancer, mainly in the context of sort of relevant background for our case. The risk and prognosis of finding incidental lung cancer on explant pathology, where it was not suspected before. And then sort of the outcome and experience with lung transplant and the setting of respiratory failure directly from a multifocal bronchoalveolar carcinoma causing restrictive findings. And then lastly, to review sort of the role of lung transplant in those with end-stage lung disease who happen to have a known but early stage lung cancer.
So I'll start with a brief overview of our patient. So this is a 71-year-old gentleman, and his past medical history is notable for TIA in 2007, from which he has no residual deficits. There was some right-sided hemiparesis at the time. He has hypertension, dyslipidemia. He has coronary artery disease and underwent PCI to the left main and LAD in 2018, and subsequently was found to have 30 to 40% in-stent restenosis in the distal left main, and this is being managed medically. He has a history of SVT, obesity with the BMI of 31. He has some cervical stenosis, small infrarenal abdominal aortic aneurysm, and a past surgical history that was notable for a right hip replacement in 2012. And prior to being assessed for lung transplant, he was on nintedanib for his ILD, Advair, Spiriva, Ventolin, aspirin, amlodipine, metoprolol, irbesartan, and rosuvastatin. And this gentleman has no allergies. So he was seen by the lung transplant service for assessment for transplantation for combined idiopathic fibrosis and COPD. He was diagnosed with IPF in 2011. He's an ex-smoker who stopped smoking in 2012. And when he was assessed by the lung transplant team in 2017, he showed some decline in his PFTs, an FEV1 that was okay at 74% of predicted, an FVC that was 68%. He had a reduction in diffusing capacity. He was quite dyspneic. And when he was seen 2 years later in April of 2019, he was desaturating using 4 liters of nasal prongs at rest. He had poor performance on a 6-minute walk test at 290 meters, and he was desaturating on that walk test. So in June 2019, a decision was made to list this gentleman for lung transplantation as single or double lung transplant. So subsequent to this, he had a PET scan in July and a CT scan in August that showed growth in a lingular nodule and a right upper lobe nodule as well. The August 2019 CT chest shows a lingular nodule that's 3.7 by 2.5 centimeters from a previous size of 3.1 centimeters by 1.7, and a right upper lobe nodule that has progressed to 2.2 centimeters from 1.8. A PET scan done around the same time shows that both these nodules are hypermetabolic, with a lingular nodule having an SUV of 23.6 and the right upper lobe nodule having an SUV of 12. So the gentleman undergoes bronchoscopy and EVAS to obtain diagnostic clarity. And the EVAS shows no evidence of malignancy in the lymph nodes, and subcarinal node and bilateral paratracheal nodes were biopsied for this. All were negative for malignancy. A radial probe EVAS guided biopsy is done to obtain sampling of the lingula. This was non-diagnostic. So subsequently, in October of 2019, CT-guided biopsy of the lingula was done. However, the lesion was obtained was small and fibrotic. Decision was made to send it solely for cytology, given its size, and the result is mixed acute and chronic inflammation. So later that same month, CT-guided biopsy of the right upper lobe nodule is done, and this confirms squamous cell carcinoma. So subsequent to this finding, the patient is delisted from lung transplant. And over here, we see the CTs from August, and you can see the right upper lobe nodule. And as well, you can also see the lingular nodule. So now there's discussion between multidisciplinary tumor board and lung transplant team. And the big questions that are being discussed is, are these lesions synchronous and have they occurred simultaneously and separately? In which case we consider the lingular mass, if it is indeed malignant, which we presume it is, despite absence of tissue biopsy, to be stage 1B. And we consider the right upper lobe nodule, from which we have obtained tissue that is confirming squamous cell, to be stage 1A. On the other hand, is the right upper lobe a contralateral tumor met, in which case we have already stage 4 disease. And given both these possibilities, do we list this patient for lung transplant or offer treatment for the lung CA without offering lung transplant? And so the considerations here are the risk of mortality after treatment for lung cancer. So the estimate of risk is that if this patient did not have ILD, if this patient did not undergo lung transplantation, and if this patient was treated for the lung cancer, there would be a 50% risk of mortality at 5 years without the ILD and without undergoing transplant. Now, with immune suppression post-transplant, risk of recurrence will almost certainly increase. However, this is a gentleman with a background of ILD who would be about to undergo radiotherapy and further treatment on what is already not ideal lungs. And do we offer this gentleman SBRT with transplant? So these are the considerations at hand. And given the risk of mortality without transplant, given the background of ILD, given his poor lung function, decision is ultimately made to list this gentleman for lung transplantation. And so in December of 2019, this gentleman undergoes double lung transplant. He's a CMV mismatch. Donor and recipient BALs are negative. He does undergo basiliximab induction and is immune suppressed with cyclosporine, slightly lower dose myfortic at 540 BID, given his cancer, and prednisone. So at the time of the OR, the explant shows T2A-N0M1A disease. And so pathology confirms keratinizing squamous cell carcinoma in the right upper lobe nodule and the lingular lesion with visceral and pleural invasion. At the time of the OR, pericardial nodularity is observed, and so pericardial nodule is extracted, and this is also showing disease. So this upstages the disease to M1A, and the tissue is sent for markers for immunotherapy, and there is a marker that's positive. It's PD-L1, quite high at 80%. And so subsequently to the transplant, in January of 2020, the patient is found to have a Candida empyema. His cultures are positive for Candida albicans. He undergoes pigtail drainage and is treated with 3 months of antifungal therapy, caspofungin IV, later switched to fluconazole PO. Subsequent to this, in March of 2020, CT shows a nodular density at the suture line of the right main bronchus, and it's thought to look slightly abnormal. So in May 2020, bronchoscopy is done. On bronchoscopy, the right bronchial anastomosis does look abnormal, and the BAL shows Pseudomonas. The biopsy shows yeast cells, but the fungal culture is negative. The patient's treated with voriconazole. And during the timing of this, the patient is also having other postoperative complications. He had splenic laceration, some atrial fibrillation, and a pulmonary embolism for which he was on treatment. So to return to the bronchial anastomosis, in June of 2020, he has bronchoscopy again. The pathology once again shows no fungal organisms, but persistent Pseudomonas. And then now at December 2020, which is a full year post-transplant, the patient describes increasing dyspnea with exertion over the past few months. He describes worsening fatigue, and a CT's chest shows an increase in a right lower paratracheal node. It was previously 0.8 centimeters, but has progressed to 1.9 centimeters within a short period of time. And so given the growth of this node, the differential would be, is this infectious? Is this a recurrence of lung cancer, or is this a post-transplant PTLD? So PET scan is done. It does show a right paratracheal node that is hypermetabolic. There's a nodule inferior to the left hilum that's hypermetabolic, and this is thought to also represent a node. There are no active lung nodules. There's some higher activity in the infraspinatus region of the scapula, and there's some persistent activity in the parotid. This is separate and is a Warthin's tumor. So if we look here, we can see the paratracheal node just behind the trachea and some calcification within it. So in January 2021, EBUS is done. This is of a paratracheal lymph node, the same one seen on CT, and the pathology confirms squamous cell carcinoma. So once again, there's discussion between the lung transplant team and the tumor board about how to proceed. And the considerations are, there's been stage 4 disease found at the time of transplant. If you recall, there was a pericardial nodule that was confirmed on pathology to have disease. And now this patient post-transplant has a recurrence with a low tumor disease burden. He has 2 lymph nodes that are positive, and he has a possible scapular infraspinatus lesion. So given the low disease burden, it's preferable to avoid chemotherapy now, given his post-transplant status and immune suppression, which could cause malignant disease to flare. And immune therapy no longer an option at post-transplant stage. So a decision is made to avoid chemotherapy, and it could be reconsidered if the tumor disease burden becomes higher. And at this time, the patient is receiving palliative SBRT to the 2 areas of disease within the chest. So I'll pass it over to Joel to tell us a little bit more about this.
Okay, so I just want to sort of go over some background related to lung cancer, lung transplant, and we'll relate back to the case. So this is a consensus document from 2015, going over sort of general selection, indications, contraindications for lung transplant. So one of the absolute contraindications listed, which is pretty standard amongst a lot of organ groups, is malignancy, either present or recent, is considered an absolute contraindication. And in the guideline, they say 2 to 5 years of disease-free from whatever cancer it was, and otherwise a low predicted chance of recurrence. And they also make mention, of course, that some patients are too high risk even after 5 years, given the recurrence risk, and still can't be transplanted. And although this list is an absolute contraindication, there is a lot of variation to actually how strictly this is adhered to, in particular, the disease-free interval. Interestingly, also in the same guideline, they talk about how a multifocal bronchoalveolar carcinoma is sort of like a non-invasive, limited invasive cancer-causing restrictive lung disease can be itself an actual indication for lung transplant, usually in those with significant respiratory impairments and significant impairments in their quality of life and no other treatment options. We'll talk about this one more a bit later. So just sort of some background, because staging obviously varies a bit from each cancer. Lung cancer, like all the cancers, uses the TNM staging system. And so we have, based on size, other characteristics of the primary tumor, lymph node status, going from closer to the tumor, such as the hilum, the mediastinum, and the further away in the mediastinum and contralateral hilum, and also the presence or absence of metastases and location of these. Generally speaking, those with sort of earlier stage disease, such as N0 or N1, can have surgery as a part of their therapy, whereas those N2, N3, or metastases tend not to be surgical therapy for treatment. In terms of prognosis, I just pulled this up to sort of illustrate how much prognosis changes as you go subtly up the staging system. So you can see here, stage 1A1, pathologic stage, after your surgery, is a 90% chance of survival at 5 years, and 1A3 is an 80% chance of survival at 5 years. That's a 10% drop. And what's interesting is that the difference in those tumor sizes is only about 1.5 centimeters. No lymph nodes, no metastases. So for example, this one here is a 0.5 centimeter tumor, and this could be a 2.5 centimeter tumor, which is still pretty darn small. And you can see as you start to have lymph nodes, stage 2A, 2B, it really starts to drop down to close to 50% survival and drops rapidly from there. And then just in the context of this, in the ISHLT guidelines, they recommend in general, at 5 years, your chance of survival should be greater than 80% when you discount CLAD, because the incidence of CLAD, of course, is high. But the basic idea is that you shouldn't have other medical comorbidities that would limit your survival to a dramatic amount at the 5-year mark beyond CLAD. And then just very basics here, the methods of staging we use in lung cancer, we usually do CT chest and abdomen pelvis, often MRI of the brain, PET scans, sometimes bone scans. And now routinely we use either endobronchial ultrasound or less commonly mediastinoscopy for invasive sampling of the mediastinum. So that's usually considered the gold standard, is to sample the lymph nodes before you do a surgical resection. And very basics here, by treatment by stage. So in stage 1 disease, so early disease, no lymph nodes at all, usually surgical therapy on its own can be curative. In stage 2 disease, it's usually they add on adjuvant chemotherapy afterwards. In the higher stages, it tends to be chemoradiation, or for stage 4, palliative chemotherapy, where it's not usually curable. And I think just something to relate back to that, because those are just guidelines from the general lung cancer population. Even those with N1 disease, they would warrant adjuvant chemotherapy. But in the setting of lung transplant and immunosuppression, giving adjuvant chemotherapy is not a simple thing, and the outcomes would likely be worse, which I'll get into as well to illustrate some studies. And PD-L1 checkpoint inhibitors have really revolutionized lung cancer care, but in the setting of organ transplant, they increase the risk of rejection and generally are also not an option. Now there's, to sort of talk about lung cancer, most of the data in lung transplants on incidental lung cancer. So that is cancer that you find on the explant pathology that you never were suspecting or had a low suspicion of pre-transplant. And they're obviously being transplanted for other reasons. So a lot of transplant patients actually have an increased risk of cancer just going into the transplant because there's smoking history, ILD, and COPD. There's also lots of patients that have indeterminate nodules or nodules that are otherwise not safe to biopsy that are not characteristic enough to sort of conclude that they are lung cancer. And then they're often diagnosed post-operatively. The other thing is that patients can have pretty dense scar and you just might not see these nodules. Now, in terms of how often this happens, one study was a survey of centers registered with the ISHLT registry, showed about 0.9% of lung transplants have incidental lung cancer. Another more recent retrospective cohort showed at one center, it was about 2.4%. And when you look through the literature, it's about 1 to 2% risk of an incidental lung cancer on explant pathology. So this is a study done locally back in 2004. They sent surveys to those that were involved in the ISHLT registry in terms of registering outcomes. And they sort of examined two questions. And so we'll talk about one aspect of the study now and one aspect later on. But they looked at those with multifocal BACs and significant respiratory impairment and their outcomes. And then also those that had incidental lung cancer explant path. And then a very small number of those people with incidental lung cancer were actually known lung cancer before, but were considered fully resectable at the time of transplant. And they're sort of lumped into with that category. And so this is basically survival curves for those that had stage 1 multifocal BAC in stage 2 and 3 in patients that are being transplanted for other end-stage lung disease. And they just happen to have these tumors, in the vast majority of cases, diagnosed incidentally. And so you can see a pretty marked difference in outcomes. The multifocal BACs have worse outcomes than the stage 1 and stage 2 and 3. So this includes those just with a simple hilar node involvement and otherwise resectable tumor in non-lung transplant population. They have terrible outcomes when they have lymph node involvement. And just sort of to summarize the numbers. So in stage 1, 64% of patients were alive without recurrence at 30 months. That was the median follow-up. 5 of the patients developed recurrence and they died within 12 months of that. Those at stage 2 and 3, 64% developed recurrence and died within 8 months of transplant. But having said that, 2 were alive without recurrence, one of them at 98 months post-transplant. Those with multifocal BACs that were otherwise incidental, they tended to have recurrence, but it took longer, around 17 months for it to recur. And then took longer from that point for them to pass away, usually around 14 months. And unlike the other carcinomas, they tend to be largely limited to the lung itself. Just to illustrate the difference in the time to recurrence, you can see here that the time to recurrence for the multifocal BACs is much longer than the other non-small cell carcinomas. And of course, again, the time from diagnosis to death also much longer. So they tend to have a more indolent course. This was the largest retrospective study that I could find, and it was quite recent. So it was from patients from 2012 to 2019, and purely incidental cancer diagnoses. If they had known preoperatively, they were not included in the study. And they were looking at the prognosis and outcomes. And so out of 247 patients transplanted in that time period, 2.4% had incidental lung cancer on path. So you can see here, you have your stage 1 and 2, they lump that together compared to your sort of non-cancer cohorts. And then you see your stage 3 and a few incidental stage 4s almost have like a vertical survival curve. It's quite a bit worse than the stage 1-2 curve. And here are their numbers. So they fall to 5 years. So overall, the survival is about 58%. And they overall didn't actually hit a median survival because more than 50% were alive at 5 years. The stage 1-2 group had about a 33% survival at 5 years. And the median survival is 19 months, and stage 3-4 was 16%, with about a 5-month median survival. So you can see that the presence of cancer worsens your outcome, but the higher stage, of course, worsens outcome as well, which sort of makes sense. Now, this is all data from incidental lung cancer. What about, those that have a known early tumor that might be otherwise resectable, but it's not because they have end-stage lung disease, such as ILD? So there's not really a lot of data that actually goes over this particular question, just because most centers don't consider those patients candidates at all, unfortunately. And so, a lot of the data is mixed in with those with incidental lung cancer cohorts. So, you might have 90% of them are incidental and a few patients are known pre-transplant. So it makes it hard to actually draw any conclusions, but we can look at what data is available. Now, the rationale from some recent reviews has been, the prognosis of stage 1 found on explant path has been reasonable. And more recent data says it's about 51% survival at 5 years based on incidental lesions for purely stage 1, which is not that much different than those that have no cancer at all. It's a little bit worse, but it's not unacceptably worse. And there's lots of patients that we transplant that we can't biopsy that are indeterminate nodules, and so they're going to go ahead for transplant anyway. The only difference is an unknown diagnosis. And there's some data, of course, in liver transplant with HCC. It's a different biology, but they've had successful outcomes in transplant for liver cancer. So this is a sort of recent review article. It goes over some of the suggested practices if you're going to consider transplant someone with known or suspected cancer, and some general recommendations that make sense. They recommend a CT chest, abdomen, pelvis, a careful risk-benefit discussion, particularly around tumor recurrence and resectability, a PET CT scan, and a mediastinal lymph node evaluation, at the very least at the time of transplant, with a backup available should there be lymph node involvement. They didn't really clarify further of N1 versus N2, but just sort of generically, there's lymph node involvement to take a backup instead, and following CT scans every 3 months while on the wait list to look for any changes that would warrant delisting. This is a study also from our local group from 2003. It's a case series that looked at 6 patients that were transplanted with end-stage lung disease and happened to have lung cancer. Now, 3 of these patients had it known preoperatively. And those that had known preoperatively had extensive imaging, bone scan, MRI of the head, and mediastinoscopy at the time of surgery. Unfortunately, 3 of the 6 patients died of widespread disseminated cancer related to recurrence. 1 of them died from graft failure around 10 months, unrelated to cancer. And 2 remained alive at 12 and 13 months. And interestingly, both of these had a known diagnosis preoperatively. So this is their table here. So you can see that patient 2, 3, and 5 had known diagnoses of cancer in addition to the underlying diagnosis for lung transplant. And one of the patients that survived to 12 months, they're at T1N0. So that's a very early stage and generally has an acceptable prognosis. And BAC, of note, the terminology's changed a bit more recently, but these tend to be more indolent cancer. So this sort of works in that patient's favor. And they had no recurrence. This patient, when I read the paper, they mentioned that in the frozen section, there was no lymph nodes that were positive, but then on the subsequent explant path, it was positive. So it was not known to be N2, and they took them to the final transplant. They ended up having N2 disease, and despite that, they were alive at a year later. This other patient had a known preoperative diagnosis. It wasn't clear what the lymph node status was, but they were otherwise T1. Unfortunately, had a recurrence and passed away. But it's interesting that 2 of the 3 patients with a known preoperative diagnosis actually had survival, whereas ones with incidental findings did not. But they also had more advanced disease, as you can see. And then this is not lung transplant literature, but this is sort of something that's relevant to lung cancer in general. When we stage patients, they go through an extensive imaging and pathologic evaluation to determine who is acceptable to take to the OR. You don't want to take people with, nodal disease in the mediastinum. But there's always an issue of, missed nodal disease, missed N2 disease, where, you take them to the OR and there's, called N2 disease, but it was after extensive, mediastinoscopies and EBUSs and PET scans. There really is no evidence of it preoperatively. In the non-transplant population, you can do adjuvant therapy and radiotherapy, less of an option post-transplant. But this study looked at a prospective cohort, and they found that despite aggressive evaluation, 8% of patients had false negative N1 disease on their preoperative evaluation. That's as in a negative EBUS, negative PET scan, negative CT scan. And 10% had a false negative N2 disease, despite that extensive workup. Which means that about 10% of patients are going to be upstaged post-transplant, despite seemingly being stage 1 disease. That's an important consideration because that makes it hard to compare the prognoses of those of the preoperative stage 1 diagnosis and those of the postoperative stage 1 diagnosis. So just to highlight that, when you're looking at people on explant pathology and they're stage 1, that's a final diagnosis. And so you can say those are final stage 1 might have a better prognosis, but when you have someone going to the OR, there is a risk that they're going to have lymph nodes and they're going to be upstaged to stage 2 and 3. And as I showed earlier, those patients with incidental finding of stage 2 and 3 cancer have a terrible prognosis with a median survival of about 8 months or less after transplant. The other indication for lung cancer and lung transplant is this sort of multifocal bronchoalveolar carcinoma. So this is a very rare indication, and as I said earlier, you should consider it when there's no nodal involvement, and the disease itself is causing significant restriction, respiratory impairment in quality of life. There's no feasible alternative to treatment. These patients tend to have a very poor prognosis without treatment, and chemotherapy and medical therapy tends to not offer, in general, a lot of benefits, although these new tyrosine kinase inhibitors can help. It's not the same benefit as resection. So again, the study that I mentioned earlier from our group, they had 26 patients that were surveyed from various centers, had multifocal BACs. 4 patients died perioperatively, 2 from graft failure, 1 from cardiogenic shock, and 1 from RV failure. 3/4 died. 3 out of 4 patients that died had a single lung transplant because of prior pneumonectomies, and 1 of the 4 that died had a prior pneumonectomy and actually had a heart single lung transplant. The remainder of patients that survived were a mixture of heart lung, bilateral lung, and single lung, majority of being bilateral lung transplant. In terms of longer term outcomes, about 13 out of 22 had recurrence. So majority of patients actually had a recurrence at some point. And of those that actually had recurrence, 3 of them were retransplanted, and 1 of them has survived to 7 years post-transplant, retransplant without recurrence, which is quite long actually for any transplant patient. Overall, their 5-year survival is 39%, 10-year 31%, which is lower than what our data would have now for lung transplant. But when you look at the ISHLT registry data from around 2004, the 5-year and 10-year survival was 45 and 23%, and wasn't actually considered significantly different. So despite recurrence, their prognosis seems to be a lot more indolent despite recurrence, and they tend to have similar, perhaps slightly less survival than a non-cancer patient going for the transplant. There was a 35% recurrence-free survival at 5 years, which is not small. Now, something just to take into account, I won't dwell on this point too long. The term bronchoalveolar carcinoma, or BAC, is still used, but it's not really a formally correct term. Around 2011, the terminology changed in terms of the pathologic classification of lung cancer, and this is important to take into account when looking at prognosis. All the data on BACs and their outcomes in transplant are from before 2011, or usually in the late 90s to mid 2000s when you look at the literature. And BAC is actually a mix of pathologies that could be called BAC in the past. So one, for example, is this alveolar carcinoma with lipidic spread. This is an extremely treatable lesion in general, essentially 100% survival with resection. And the minimally invasive adenocarcinoma is not quite as good, but still can be over 90% survival with resection. It has a very low chance of metastases and lymph node involvement. So these patients would be expected to have a pretty good outcome if you took out the lungs by whatever means, surgery or transplant. But then they lumped in the past, patients with invasive mucinous carcinoma, which actually have a much, much worse prognosis, potentially as low as 50%. And so it's hard to interpret, poor prognosis after lung transplant for BACs, because some of these patients in the past would have had mucinous carcinomas, but we didn't divide it up that way. And so I think if you were to redo these studies with the more benign variants, you might see different outcomes. And just to sort of illustrate the variation in prognosis, these are sort of summary of some studies up until about 2012, including studies that I've already mentioned. But they have a variable number of patients, generally small, except for the ones that I highlighted. And their 2-year and 5-year survivals, you can see vary quite a bit. The first study that looked at BACs and transplant was a 100% survival for the one patient at 5 years. Whereas, other ones, for example, the one I talked about was 60% survival at 2 years and 45% at 5 years. And for stage 1 lung cancer, is about 50% survival at 5 years. So, there's a lot of variation in how good or bad people's outcomes are, because the data sets are small. There's varying definitions of what BACs are, and there's varying ways that people have gone to stage preoperatively, depending on the era that they were transplanted. So it's a bit hard to interpret, what the right thing is based on sort of limited data available. So I guess to summarize, the literature and sort of related back to the case, in general, lung cancer remains an absolute contraindication to lung transplant. But in the setting of very carefully selected patients with truly early pre-invasive, minimally invasive disease, no lymph node involvement, they might actually have an acceptable prognosis. And this is based largely on incidental lung cancer diagnoses and their evaluation. But it also requires a very extensive preoperative evaluation. And you are taking the risk of missed nodal disease, subsequent upstaging, and a very terrible early outcome in a subset of your patients that were otherwise stage 1. And then in setting of multifocal bronchoalveolar carcinomas, patients may themselves have individual benefit in terms of quality of life and survival. The recurrence tends to be high, but tends to be more indolent and prolonged, which means that their outcomes, albeit, are probably worse than those with non-BAC diagnoses. They tend to not be so much worse than the general population that it's reasonable to consider that in a subset of patients. But overall, there's no real high quality data or large volume experience to guide this decision. And, like in our case, you try to do the best to help your patient and give them individual benefit. And there's always, the ethical obligation to other patients on the wait list, and, limited donor organ availability is always an issue, particularly in lung transplant. So there's no real one right way of doing it. And there's always, that ethical balance. So these are references. So I guess at this point, we're happy to take any questions about the case or about the literature review.
Thanks so much. Sorry, this is my first time using this equipment, so just bear with me. If you have any questions, please raise your hand and I'll try to make sure that I can see that. Maybe I'll just start off. So you presented some data from Toronto. Was this all retrospective data from incidentally found lesions, or do you have any sort of protocol, or what are you guys currently doing, if I may ask?
So I'll cycle back to that study. The study. So it was effectively retrospective. It was not data limited just to our center. It was for all of those that were registered in the ISHLT registry for sort of international outcomes, and they sent out a surveys to those groups. The other study that I highlighted later on here, this was a case series, so it was all retrospective from what I understand. I think most of the data is retrospective. Dr. Fernandez, you might be able to comment on this as well, but
actually, I can comment at Shaf here. So,
okay.
So over time, when you're following patients on the lung transplant list, sometimes you can get burned by, especially in IPF, where it's hard to see a subtle change in densities that could be pulmonary fibrosis, but it could be a cancer developing. So, over the years, we've gotten surprised at the time of transplant with that. And that's what prompted us to look at this first paper that, where we had anecdotal long-term survivors, what is the experience around the world? And it was very small, so we polled everybody in the International Society of Heart and Lung Transplant. And if you go to the survival curve here, go to the next slide. I think what was really, that one from the first paper.
Yeah.
If you look at the dotted line, that was all transplants at the time in the registry. And you could see the incidental cancer patients that were stage 1 were fine. If it was higher than that, it was not fine. The other important thing is the multifocal BAC patients. You can see that their 5-year survival is about 20 to 30%. And Joel showed you from other people's experience. But the indication for transplant for bilateral bronchoalveolar carcinoma is the patients dying of respiratory failure. These people are choking because of their cancer. And so it was very advanced disease with no other options. Like, these people would be dead in 3 to 6 months. So to get a 30% 5-year survival in that group for that patient is pretty remarkable, and still worth doing, or arguably worth doing, for that patient. And certainly when we got to the stage like just before COVID, where we had more lungs than patients to put them in, the argument of harming other patients on the wait list by treating higher risk patients really was less of an issue for us when we were rationing lungs because of shortage of donor organs. But the question is that all cancers have a higher risk in an immunosuppressed patient. So what can we do to improve on them? The biggest improvement in the treatment of lung cancer has been the immunotherapies, and that's a huge problem because it's immunotherapy in the opposite direction to what we need in transplant. So the best advance in systemic therapy really hasn't helped transplant patients. So I wonder if Mark Dippero's on. I think he has a lot of interest in this area. Mark, if you can comment on our new trial and some of the things that we're doing to try and explore the area of transplant in patients with cancer or suspected cancer.
Yeah, thanks, Shaf. Thanks for the review. That was an excellent presentation on difficult topic, limited data. So there are changes that have occurred, I think, since we published that paper. And one of them is the radiation, the ablative dose of radiation, the SBRT, which is increasingly used for stage 1. And what we see is that the SBRT is immunogenic, so you generate an immune stimulation on that immune effect is persistent after you remove the tumor. So the effect of radiation on stage 1 is potentially something that could be beneficial, and that's what we're investigating now. And what we've also seen is that if you give a lower dose of radiation than the ablative dose of radiation, you actually stimulate the immune system much more efficiently. So if you give a subablative dose of radiation prior to doing the resection, you can generate an immune activation that potentially can limit the effect of the immunosuppression. So the immune activation basically may be able to prevent the side effect of the immunosuppression on the progression of the tumor post-transplant. So that's where we what we are looking at now with a new trial. So it's an evolving field. I think the fact that you have more lungs available is certainly a big change in what we were able to do. And the patients you described, actually, that set of lungs was not feeding anybody else on the list. So it's actually was a potential advantage which we didn't have in the past. And that's certainly part of the reason we are now looking at the option of potentially transplanting patients with stage 1. The other part is the fact that often you have patients with emphysema or pulmonary fibrosis, and then you have these nodules, and you don't really know if it's malignant or not until you take the lung out. But having the ability to radiate this tumor with a subablative dose prior to the transplant may potentially be beneficial prior to transplant to limit the risk of progression and also post-transplant, as I mentioned before. So it is also sometimes difficult to tease out whether patients have malignancy pre-op or not. these patients don't have any other treatment option. Patients with pulmonary fibrosis very hardly will go on to have any type of treatment. So they really are purely palliative with very often no chemotherapy, no radiation, and certainly no surgery. So for young patients, there are some options that I think transplant may offer that are potentially in very selected patients beneficial. So this is an area of development, but certainly an important area, I think. So, but the radiation certainly seems to be an opportunity that we didn't estimate as much, 15 years ago, which may change, some of the outcome post-transplant.
I wonder, are any of the liver transplant group have a much more experience of transplant for cancer, and also now, obviously, I don't know if Gonzalo is looking at liver transplant for metastatic colorectal cancer to the liver. Are there advances in immunotherapy or changes in strategy to deal with those patients?
So I'm not sure if Gonzalo is on. If not, then I can comment. So we have a trial going on for liver transplantation for colorectal metastasis. And this came out of a series from Norwegian, Scandinavia initially, which also had more livers than patients. And they actually reported very good results. And we initiated the same study with live donors only in Toronto at this point. And the target is less cure, but survival. So interestingly, while the natural course of the disease is a survival of 6-9 months, the 5-year survival after transplant is like 80%. So, although many people recur for reasons we don't understand, the long-term survival seems to be excellent with the limited data we have at the moment. Key is selecting the patients right. So you select patients which have responded to chemotherapy, have stable disease, cannot be resected, but are controlled with chemotherapy. And these patients tend to do extremely well.
One question, maybe Marcus, that I may ask, the use of immunotherapy pre-transplant, is that, and then stop at the time of transplant, will that have the same impact post-transplant, or is it an area that hasn't yet been investigated? Is there any data on pre-transplant immunotherapy on the risk post-transplant?
I'm not aware of any immunotherapy pre-transplant. I mean, they all get chemotherapy pre-transplant. And I think what we're doing with the chemotherapy, we're selecting the favorable biology patient. I mean, those who have stable disease under chemotherapy are likely the patients who have a good biology and do well afterwards. And interestingly, they do get lung metastasis afterwards, but they live long. So interestingly, the patients don't die of liver failure, and the long-term outcome is good. But I'm not sure about any immunotherapy these patients.
Mm-hmm.
I think generally, patients who have been started on immunotherapy, they were usually put on hold for transplant for at least 9 months. So it's difficult, I think, now, like the oncologists want to start immunotherapy, but they generally won't do it unless the patient is not a transplant candidate.
Mm-hmm.
And the good thing is using live donors for it, that we can plan the transplant. So we know exactly when the transplant is going to happen. So we could do the immunotherapy or chemotherapy in a certain interval, and we know exactly on May 25th we do the transplant. So that is, I would say, the advantage for the liver program.
Mm-hmm.
Any other questions? Or here. So Dr. Khashoggi, would you still suggest pre-op mediastinoscopy with frozen section prior to decision to transplant, or EBUS in those who would tolerate it, and would N2 have the implication of stopping the procedure?
Yeah, no, that's a very tough question, obviously coming from one of our senior fellows who knows the problem. Yeah, no, Christina, I think that's pretty tough, but with EBUS and PET, and we do repeat staging every 3 months with PET and CT. We you know, haven't had to do mediastinoscopy in a backup recipient, you know, but again, I think we would need to revisit that and sort of say that if there's bulky N2, we need to figure it out one way or the other. If the EBUS was negative and the nodes remain small and the PET remains negative, I think we would just go ahead, and there is a risk that we'll end up finding N2 at the time of surgery. But you know, if these patients get so sick that you can't restage them, that's often a double bind. And I think, you know, those few that have lived a long time, like on this survival curve, like we remember those, and even the one that was retransplanted and lived for many years after her retransplant. Many of these BAC patients are young women who never smoked, you know, and so we sort of push the limits a bit. But I don't know, Mark, what do you think about Christina's question? Should we do MEADS and have a backup recipient?
Yeah, no, I mean, I agree with you. I think, I mean, we've done that initially, and it's just logistically a bit complicated on you know, to get a frozen section in the middle of the night. On ideally, they should have an EBUS on, hopefully, you know, on not too long of a wait time. But I think that's probably a better way to do it than a frozen section intra. But I think a pre-op or pre-listing EBUS is probably the most important if it can be done.
And the other thing is our medical oncologists have gotten much more experienced in giving conventional systemic chemotherapy in immunosuppressed patients. So, you know, some of our patients have had real, you know, adjuvant chemotherapy, because if you find N2 disease, or N1 even, you know, it's an increased risk. So it's not that there's no systemic therapy, but the advances, the immunotherapy isn't great, you know.
You know, another thing I think that is evolving is the interaction between the tumor and the immune system. Like the tumor mutational burden, you know, is a marker of immunogenic tumor, and these are potentially those that are more susceptible to immunosuppression post-op. So the other, you know, factor that I think will progressively come up as, you know, risk factor that will probably be more helpful to identify pre-op as to what is going to be the effect of immunosuppression post, you know, post tumor resection, basically. So with the transplant, so you know, as the field evolves, I think, and as we understand the interaction of the, you know, the tumor and the immune system, I think we'll have better marker from the tumor itself. And so nodal status is important, but there may be other parameters that may help eventually.
And just for everybody's information, I mean, we've been giving this a lot of thought to see, and as Mark said, we've got this neat trial of the abscopal effect of radiation and trying to take advantage of that. Mm-hmm. So we've put together a group in thoracic surgery, medical oncology, and radiation oncology to evaluate patients with cancer that might be considered for transplant. And in some ways, transplant is the ultimate cancer operation for some patients, where the only way to get the cancer out is take the whole lung out, and they don't have enough lung function. Either they've had a previous pneumonectomy or something. Like occasionally we'll have a patient who's had a pneumonectomy 15 years ago, and they get a new lung cancer in their only lung that's got emphysema in it, and they got limited lung function. They can't tolerate destruction of lung from radiation. They won't, you know, chemotherapy isn't great. So, but it's totally resectable, except they don't have any lung. Can we just give them a new lung? You know, so I think these are areas to explore. And so we're trying to look at it in a multidisciplinary way so that we can make these difficult decisions together.
Yeah, the other area that is changing is the tumor, you know, cell-free DNA. So we have the ability, you know, to monitor the tumor, you know, in the blood with the molecular molecular marker. So that's also an area that is evolving, and that may help us post-transplant. We identify patients who may be at higher risk and intervene earlier than waiting for an abnormality on the CT or the PET scan. So
actually, that's interesting, Mark. Do you know, do you get a cell-free DNA signal in the peripheral blood with SBRT?
It probably, yeah, I'm not sure it's been investigated actually, but it would be very interesting to look at the. So we've looked at, it wasn't cell-free DNA, in mesothelioma, but it was some of the cytokine on growth factor. And if you give that subablative dose of radiation in the SMARTER protocol, you see a normalization of these marker, within 10 days of the radiation at the time of surgery in the mesothelioma patients. So that subablative dose of radiation has an impact, and it may well have an impact on the cell-free DNA, I suspect. So it'll be very interesting to look at. Yeah.
We should ask John if we can tag that onto our study.
Yeah.
Add cell-free DNA.
Yeah.
Okay.
Are there any other questions?
Maybe no questions, but just a comment about. I don't think our fellows, and we haven't had a BAC in a long time, but I would probably echo what Shav said about the quality of life of these patients that came with respiratory failure, and giving them 5, 6 years of life was really very meaningful for them. A couple of them had small kids, so it was really nice to see that they were able to actually spend time with them. One of them, actually, we were considering for retransplant because her BAC was the only one that had not recurred, because most of the other ones, or all the other ones, had recurrence. And that is important. We tell the patients we do transplant in this patient, BAC, I'm talking specifically, as a palliative really treatment. It's not that we are going to cure them, and we don't look for cure, but it's just to offer a palliative really approach. But again, they are offered survival of 5 years or 6 years, and I think that is quite meaningful to them. So again, I'm talking about specifically the BAC, but it has been quite incredible to see how they will do it again. If that were the case, they have had really good quality of life after that transplant.
Thank you so much. Unless there are any other questions or comments? Okay, well, thank you so much for that excellent presentation and for the really fascinating discussion. I think we all learned quite a bit. Thank you so much.
Of course, yeah. Thank you.
Thank you.